Ngā mihi and thank you. Tēnā koutou, tēnā koutou, tēnā koutou. Ko Waio, ko Taranaki te maunga, ko te Atiawa te iwi, ko Ngaire, Keenan tōku ingoa. Kia ora. My name is Ngaire and I am a paediatric trainee from Aotearoa. And today I'm going to talk about epilepsy. As you will all know, although some people with epilepsy can and do live normal lives, epilepsy is commonly associated with poorer quality of life. 30% of children have seizures resistant to anti-seizure medications, and in the most severe epilepsy types, 25% of children will die before 20 years of age. The World Health Organization has declared epilepsy to be the most common serious brain disorder worldwide. It has no racial, social class, or geographic boundaries. And so we know that epilepsy has this huge global impact. My question today is, how does epilepsy impact children in Aotearoa, New Zealand? So how have I figured this out? By using the New Zealand Pharmaceutical Database, we identified all children with treated epilepsy in the Auckland and Wellington regions. This is 48% of the New Zealand paediatric population. We included every single Māori child and a comparison group of non-Māori, non-Pacifica children with treated epilepsy. Every single clinical notes was reviewed to identify epilepsy type, etiology, and the care that they received. And so I could talk about this all day, but there's just a few pertinent points that I'm going to mention. The first is that the rate of epilepsy in Māori children is actually the same as non-Māori children. When we take into account socioeconomic status, however, the rate of epilepsy in Māori children is significantly lower than New Zealand European children. And this is important because it suggests that the rate of epilepsy in Māori is driven up by social factors. So when I looked at the causes of epilepsy, I identified that Māori children are 1.5 times more likely to have a structural cause for the epilepsy, and more concerningly, 4.6 times more likely to have an infectious etiology. And this is important because it raises the question of preventability. And so when I looked at preventable causes of epilepsy, I identified that Māori children are 2.7 times more likely to have a preventable cause. When I adjusted for socioeconomic status and how far people live from hospital, this rate did not substantially change. And this now leads me to epilepsy healthcare. And I'm going to use a pathway approach. So Māori and non-Māori, non-Pacifica children actually enter the health system in the same way. But this is where things will start to change. Because when a Māori person enters ED, they are 1.7 times more likely to get sent home. And as we all know, this is important because when you get admitted to hospital, you see a medical specialist within 24 hours. And now look at the other side of presentations, so via the outpatient department. I identified that when you calculate the time from presenting to the health system to seeing a specialist, Māori waited 4.5 weeks longer for their very first specialist appointment. So this is anybody who can care for epilepsy, either a general paediatrician or a neurologist. When I look specifically at neurology healthcare, Māori were 2.3 times less likely to see a neurologist if indicated to do so. And what's more, if they did see a neurologist, they waited 5 years longer for that appointment. Similar trends were seen in access to investigations. Māori were less likely to receive an MRI scan if they were indicated to receive one and waited 12 weeks longer for that very first scan. Māori additionally waited 3 weeks longer for their very first EEG. And so in summary, this study has identified a substantial number of inequities that negatively impact Māori children with epilepsy. And what's more, these inequities are avoidable and, in my view, unjust. An important step now is to not only analyse what this research means here and now in the present, but also to look forward to the future and consider how we can take this information that we have gained and turn it into positive and sustainable change. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou.
Thanks. Question?
Oh, I think this is awesome. I just think the way you have gone through every single step and the way you have disaggregated being Maori, which is what people will do, and they do it with Aboriginal families as well, as the problem. That's not the issue. It's totally socially driven. And I like the fact that you could go to a whole bunch of departments with your pathway analysis, which is really cool, and say, okay, what are you going to do to stop the fact that there is such an inequitable time for neurologists, because this is really showing that the health system is another adverse social determinant of health and possibly discriminatory. I think it should be called.
Yeah, I agree. It's 100%. And what I haven't shown here is that, because when you expand it out, it's this whole pathway. And then we've taken another analysis where we've taken into account socioeconomic status and rurality. And although some of those red circles do disappear, a lot of them don't disappear. So not only is it social, but there's actually cultural factors that need to be adjusted, which is why we need a health system that is equitable and culturally appropriate and historically considerate as well. And so that is also important steps into improving our health. I think this is quite shocking data. I think people realise it was quite so bad.
In terms of kind of infectious causes, do you know if the ones reported are mostly acquired very early in childhood? Are they seen preventable precipitants?
Yeah, so a lot of them were stuff like bacterial meningitis or HSV, meningoencephalitis. In terms of the preventable causes, in order to be classified as what we decided preventable is that it had to be essentially preventable. So bacterial meningitis, there are immunisations to help prevent that.